What we aim to show today is retrograde drilling of the femoral socket using the existing footprint of the ACL in surgical reconstruction of the anterior cruciate ligament. Here we see the rather large footprint of the anterior cruciate ligament on the lateral wall of the femur and the synovium overlaying the posterior cruciate immediately adjacent. Here we're looking through the anteromedial portal into the back spaces of the knee. We see the reflection of the synovium and the end of the articular cartilage where they converge. As we retract the scope distally, and that is straight distally along the line of the femur, we pass right above the center of the ACL footprint. Here we're using a radio frequency cutter, and starting from the back where the articular cartilage and synovial reflection met, we are going straight in line with the femur. That's straight distal in the anatomy. So here we have cauterized through the middle of the femur, and we can clearly see large amounts of ACL footprint above and below the cauterized region. We are careful not to clean off the entire stump of the ACL because we want existing fibers to remain in their anatomic location so we can use them for targeting. So we really would like to clean off only a swath through the middle of the footprint, leaving plenty of ligament left to be certain where the footprint is. Again, with the arthroscope in the anteromedial portal and the femoral guide for the retrocutter through the anterolateral portal, the guide is placed exactly where we would like, in the middle of the ACL footprint, and the retrocutter is drilled very precisely into this location. The cutter is flipped, and then the socket is made to the desired depth. Similarly, the rounded tibial guide is used to find the middle of the tibial footprint, and the appropriate size hole is drilled from the outside in. Through this hole, the four-stranded hamstring graft is pulled into the femoral socket and tension. So here we see that the graft is anatomically positioned on the lateral wall of the femur, posteriorly and distal. We can see this directly. There is no PCL impingement, and there is no graft reaching towards the superior position of the intercondylar notch. Here is another footprint. We are carefully using the radio frequency device to cut down the size of the ACL footprint. Once we have a good view of it, we can find our spot of origin in the back where the articular cartilage meets the synovium. Then, putting the radio frequency cautery here, we pull straight in line with the femur, which would be straight distally, and make a swath through the middle of the ACL. We go further distal, and we are able to see the lateral intercondylar ridge, which we have cleaned off. And again, we see ACL remnants above and below the swath we have cut.